how to do that. And thank you, Olivia. So the reminders for how to do the closed captions, and if you are struggling after we switch to the next slide, you can also just put in a text and we can give you instructions that way. All right, next slide, please. All right, as a reminder, this is a NIDA-funded initiative to advance the science on recovery community centers. So our goal is, as you know, to bring together multi-stakeholder groups so that we can all talk across our silos and help each other out in building the science on recovery community centers. So just like everybody in the room here, our steering committee that talks about what we should put into our seminar series and what initiatives we're going to do are also from different stakeholder groups, and you probably recognize all these names and faces at this point. Next slide. Our group here, in turn, is part of an even larger group, the Consortium on Addiction Recovery Sciences, also funded by the National Institute on Drug Abuse. And these are different teams like our team that is also seeking to advance science in the peer recovery support services space and recovery science in general. And we just have this slide here to remind you of upcoming events. This will be in the email you will all receive in a couple of days from now with all the materials. So we won't go over all these items, but you will get these slides, and then you can click on these links and explore further, and I encourage you guys to do it. Here I will highlight the online conference, the National Conference on Addiction Recovery Science on April 24th and 25th. If you want to talk science in this space, please do show up for this event. Next slide. We're going on to our polling questions. And if you can go ahead and start the poll, these are demographic questions to just see who's in the room, to see if you're really reaching our different stakeholder groups. And then as usual, we have a little bit of questioning for the upcoming topic of today's seminar. So I'll give you all a moment to fill this out. For the last item here about suggestions you have for RCCs, if you put them into the text box in the poll, we will be able to see them, we can share them, and they'll remain anonymous. But if you're comfortable, and I hope you are, to just share them in the chat with everybody, that would be great. Just food for thought for, have you tried this? Or this worked for us, or I wonder if this could be done. Any and all suggestions would be wonderful. Thanks, Joe. And how are we doing on completion, Olivia?
We're at 65%.
All right, we'll give it a couple more minutes. Yeah, I like that, Cindy Marie. And also feel free to just talk, unmute yourself while we're waiting for a poll to complete anyway, so suggestions cannot just same as well. All right, where are we at, Olivia?
78.
Ooh, so close to 80. 80, so we cut it off, guys. So you can tell that this is run by scientists, right? Because we love our data, so we always hold off for more. All right, thank you. You can close close the poll so everybody can see it. So if you use your bar at the side, you can scroll through all the answers. And we have a lot of people with lived experience in the room, which is great, recovery advocates. We also have some scientists here, some clinicians, so, and of course, RCC leaders and participants. So that's our audience here today. And for the answers to the questions, we ask who would be the hardest group or agency to engage with for RCCs? And the runaway answer here is the medical centers that most of us thought it would be the hardest. And there was 0 for recovery housing, which is great. All right. And then suggestions, you can see your own answers. 39% of you guys answered, which is awesome. Thank you guys for the suggestions. We'll be sure and look for them. We'll be putting those materials anonymous on the website, so you guys will be able to have them. We'll email those out. Thank you guys for typing in those answers. All right. If we can go on to the next slide. We do have an active list of RCCs. So we have 2 lists. We have a list of all the live features. In case you wanted to have a quick link to all the live features we've had before, there's a list we have for that. And we also have a list of RCCs that we maintain. We started with a nationwide survey we did and expanded thereafter, in case you want to do another large-scale study like that again, and we would love to. So if you are not on our list, and I think Ellie just put the list in the chat here, or you know of new RCCs that we don't have on the list, we would absolutely love to have them on this list, so that because sometimes people ask us.
You divide 96 by 4.
People sometimes ask us, is there an RCC near me? And then we want to tell them, yes, there is. And here is the contact information. So if you can put that into the chat, that would be wonderful, or email us afterwards. Next slide. Thank you, Trevor. All right. And as you know, for all of our seminars, we start with a live feature. And the reason is we want everybody in the room to be grounded in what we're actually talking about. And most of us know what RCCs are. Many of us don't. And that's exactly who we want to reach, the people who are not as familiar with RCCs, so we can learn from each other. And today we have with us Justin Buck, who is going to tell us about Wolfe Street Foundation. Justin, can you take it away and tell us what happens when people walk through the door of your RCC?
Yeah, absolutely. Thank you. My name's Justin Buck. I live in Little Rock, Arkansas. I'm a lifelong Arkansan. And when you walk into the doors of our Recovery Community Center, since 1982, something I can tell you that's true is there's a meeting about to start. So whether it's 6:45 on a Monday morning or 10 o'clock at night on a Friday or Saturday, there is a 12-step, a faith-based, some kind of recovery pathway, mutual aid support meeting about to start. So we have about 50 something meetings across any given week. They are free to attend. They are open to the public. And that comes from our history. Like, that's the legacy of our mission since we opened in 1982. And across that time, we've moved locations once, which was tough. We've endured COVID, which was tougher. And our meeting attendance is creeping back up. But over that time, we've also evolved to meet the needs of our community. So as a Recovery Community Center, we started probably about 4 or 5 years ago offering peer recovery support services. We started with 1 peer specialist. We did not know what to do with them, but we have learned well. And most of that's because our RCC is led by people with lived experience who can appreciate how powerful it is when a peer recovery support specialist or someone with lived experience in recovery connects with that person who's seeking help and navigates them to the resources that they need. Over that time, we've also launched other programs like a recovery housing program. We work with the criminal justice system. We work with treatment providers and medical providers. But we always try to get folks through the door at our Recovery Community Center, because what we want people to find is a true community of people who have shared those experiences and are working together to share that experience, strength, and hope, because when you give it away, it multiplies. It doesn't get reduced. So you'll also find when you walk into our Recovery Community Center in downtown Little Rock, there's someone there to greet you, no matter when you're coming in or what kind of help that you need, to listen and to get you to the person who can best help. I'm also really proud that just about every month, you're going to find us not in the doors of that RCC, but outside having some kind of event, whether that's one of our sober celebrations that's around the holiday seasons, or it's an outreach event that we're doing into our community. And finally, I want to mention, community is in the word. So we're building a robust and resilient recovery community right here where people can find what they need, but we also integrate into our home community. So about a year ago, when tornadoes ripped through the heart of Little Rock, we responded by opening the Recovery Community Center to the whole community, because we had power, because we had a commercial kitchen, and we started meeting those needs and bringing people in recovery and people from our broader community together to cook meals and get 5,000 hot meals out to people who were without a home, without heat, without cooking abilities, and get 72,000 bottles of water and 300 volunteers into our community. So when you walk into the doors of our RCC, you're going to find folks who are happy to see you. And you're also going to find opportunities to walk back out those doors and be a crucial, critical part of the broader community that we live in.
That's awesome. Thank you, Justin. And I think you're already previewing so much about the outreach you're doing. I love the opening of a center and really using the resources you have to share in a moment of crisis. That's awesome. All right, if you can move us to the next slide, Olivia. Oh, I was gonna go one for, but no, actually we'll stay here, my bad. So I was gonna show you who's gonna be our panelists today, because today we're gonna do something a little bit different. So oftentimes we have presenters who present their studies and their findings, and then we have discussants from different stakeholder groups to kind of inform more and from different perspectives what that means in their context. Today, we're going to be doing a moderated discussion with 3 directors from 3 different RCCs, and we're going to be talking about outreach. And the reason we wanted to do that is because, as you know, we've probably seen our series before, our nationwide survey showed that RCCs are doing great in terms of reaching groups that formal treatment services are less able to engage. So in this slide here, we're breaking it down by rural and non-rural RCCs that we were able to contact for our nationwide survey. And I think Ellie is putting the link to the full paper in the chat for you all. So you have the original reference for that as well. And the differences, there was, the differences in demographics that I'll talk about in a moment, but from a total number you can see here is that RCCs are able to engage young adults. So 1 in 5 participants were young adults, and they're able to engage ethnic and racial minorities. For example, 1 in 5 participants was Black. And this is a lot better than a lot of treatment centers and settings can do. So when we share this with our colleagues, they always say, well, how do these RCCs do that? How do they engage folks? How do they get them to participate? Then they won't participate elsewhere. So we thought we'll spell it out. We'll explore it and we'll put it here so people can find that answer to that question. So if you can move us to the next slide, Olivia. So we invited 3 directors. We have Randy Rush, Jenifer Langston, and we have already heard from Justin Bach. Jenifer, are you already here? I know there was a hiccup. Are you with us, Jenifer? Not yet. So we will have Randy and Justin to talk with us, and hopefully Jenifer will be able to log in and talk with us about it as well, to do a moderate discussion today. And I think we can probably stop screen sharing so we can all see each other better. And spoiler alert, all of us talked already on Tuesday about it, so they are not going to be surprised with the questions I'm about to ask them. But I wanted to say, so we are going to be talking about the nitty-gritty that you saw in the polling questions earlier today about, different agencies and direct-to-participant kind of communication. But before we go into the nitty-gritty, I really wanted to ask you, Justin and Randy, what is the mission and vision that you have and that you share when you approach people? Like, what's your philosophy? What's the mission and vision that you use in the outreach? Who wants to go first? Go ahead.
Yeah,
okay.
So our mission is really to provide a safe and supportive setting for individuals and families on their road to recovery from substance misuse and substance abuse. And so that's, one of the things that we want people, you talk about how do they engage us. We want to make sure when people come in, we're the anti-treatment place. You know what I mean?
Can you actually spell that out a little bit?
Yeah, I mean, it's no cinder block brick, You know, it's warm, it's inviting. You know, if my staff wants to decorate their office in a way that is important to them, it looks like, you know, I've got a couple of people. I mean, their offices look like it's a throwback to San Francisco in the 70s. It's hippie central, you know, but that's okay, because the message we're wanting to send to people when they walk in, that it is a safe place. It's a non-shaming, non-judgmental place. And it's a place where it's just not a medical office or a treatment facility. So.
Great, great. What about you, Justin?
Yeah. Our mission has evolved. We've been around for quite a while. So when we started, you know, our mission included a phrase that said exclusively for the benefit of members of Alcoholics Anonymous. And so over the years, our mission has really expanded, because we know that recovery, like our philosophy is that recovery is most powerful when we do it together. We recover best when we recover together. And so we've really opened up to be more inclusive of multiple pathway recovery. We've really opened up by providing these direct services. So our mission today looks a lot different. It's not exclusive to Alcoholics Anonymous. I always have to qualify that by saying, hey, we still have dozens of Alcoholics Anonymous meetings in our Recovery Community Center every single week. It's just that we're not restricted to just that fellowship or just that pathway. And so, you know, our mission today looks more like helping people and families survive and recover from substance use disorders. And that gets at the heart of what we're trying to do, is building a community that's ready to receive people. Like Randy mentioned, you know, it's a warm and welcoming place. There's a rolling pot of coffee on the burner. There's resources for what you may need. And it doesn't, we also, you know, part of our philosophy is not prescribing to someone what they need to do, but listening to what goals they have and how we can help them achieve those goals.
Yeah. And how do you mention, so you reach out, so you have to set up relationships with different agencies, different groups around you. And in that discussion, do you, like, is that what you lead with, that it's multiple pathways, or is it like, what do you lead with? How do you make those connections?
Yeah, I mean, for us, as Justin mentioned in his introduction, the first thing we lead with is lived experience, right? That our organization is built around the lived experience of people who either suffered from, you know, or dealing with substance misuse and substance abuse disorders, or you're the family member. You know, that for us, family, we were started from the very beginning that the families were an integral part of this. And, you know, so we have quite a few of our board members who are the family members of someone, mainly parents for the most part. And so for us, when we go out, it is that kind of idea that, you know, these are folks that have walked that walk, and that they can, you know, connect with your people, whoever you're referring, in a way that maybe others can't. You know, I was looking at a resume not too long ago, and, you know, all of a sudden I came out of the corporate world and was on the board before I took this role. And I'm reading through this person's resume, and I'm like, my corporate hat came back on, and I'm like, wait a minute, there's a gap here. What is that? My program manager said, that's where they were getting the experience necessary to be effective in this job. Like, oh yeah, right. You know, so, you know, it is that lived experience is what we lead with.
Yeah, I would second that, is that the thing that breaks down barriers and creates immediate rapport is that shared lived experience, you know, and for us, you know, almost all of our, well, I would say all of our services are rooted in peer recovery support services, and that's a powerful link between our participants and our peer specialists, is that they know that this is a person who is not here from a place of judgment. Yeah, Michael in the chat says peers bring hope, and like that's the richest tradition, in my opinion, for the Wolfe Street Foundation. That's the richest tradition that continues today, is from, you know, what we call mutual aid. Okay, well, yeah, that's what still happens today. We have it's kind of been professionalized a little bit. I know that there are healthy criticisms of that in the field, but it's brought a lot more resources and focus to the way that we implement and the way that we wield that shared lived experience to make a big difference.
That makes a lot of sense. So in our polling question, we talked about who's the easiest and the hardest to engage, and folks in the room think that building this relationship is hard at some medical centers. Which one do you want to go first? You want to do easiest or hardest first?
You pick.
All right, let's talk about the easiest. Who's the easiest for you all to work with? To like set up referral systems and have a close working relationship with agencies in your communities. Who is the easiest to do that outreach with?
Yeah, I would say for us the easiest has been the criminal justice system. I think just because the need is so great, and that they are looking for resources. Our price is right because it's free, so that's always a plus. But we did a couple of things. We built a relationship with like one of the local probation, pardon, and parole offices, and it was part of a small grant. And we went out and we did listening sessions and talked to the participants of what it would look like. And we learned a lot through that. Right, we were going to go in and have meetings in their offices, and one of the participants said, no, last time they called me up and told me to come here and something had met, I thought I was just coming to do something, and they rearrested me because of some snafu somewhere, and I'm afraid to come here. So we learned, well, we can't have meetings and do peer support in the probation, pardon, and parole office. But when they would come to our place, they said, hey, this feels safe. And the parole officers and the people that were in charge of that have been great. And so one of the things that we did is we hired a retired person from the criminal justice system just to work a couple of days to do outreach. And so we've moved into other counties. We would say, hey, we're going to go move in the next county. Can you help us? She goes, oh, yeah, that person worked for me for 10 years. I know them. I'll just call them up and go have lunch. Well, great. That sounds super, And they've been the easiest.
Wonderful. Same for you, Justin. Is that the easiest criminal legal
Yeah,
system?
yeah, and I was gonna say easiest and maybe hardest at the same time, but the easiest time we have finding people to work with is when we can offer those services for free. So maybe stepping a little into controversy here, but like yeah, when the price is right, like Randy said, I have no problem working with criminal justice system, especially even medical settings and things like that. As long as there's no cost to the program, it's really easy to work with folks. Now, when we start talking about the sustainability of those services and how everything costs money, sometimes those working relationships start to look a little different.
That's challenging, but necessary. And so this is still something that you're navigating and figuring out how to do that. Yeah. So who is the hardest? And actually, there was a comment from Michael here. Let me just see. Michael, do you want to chime in here, or do you want me to just read it out loud?
Oh, feel free. I just wanted to just share how important it is for reentry based on the data that we see at SAMHSA regarding overdose deaths, and really, the connection for individuals that really want to sustain and keep their recovery is really where the peers can support their recovery before their release, so that they do have a hopeful process and being able to stay engaged in community supports, as well as getting connected to primary and behavioral health care. So what a win-win-win that is when we work with those communities within the system. Thank you.
Yeah, perfect. Thank you for
and Bettina, that's why we continue to go into jails, prisons, other places, even on the treatment center or medical side. If we can connect with someone before discharge, before release, yeah, they're going to feel a lot more comfortable walking in the doors of our recovery community center and continuing to participate in programs that because I really see our role in those systems as a bridge back to community, a bridge back to connection, because so many times those incarceration or treatment experiences are very isolating. And so, all right, how do we bridge you back and make sure there's a community waiting and ready and excited to receive you?
And I will say that I think it's amazing and wonderful that you are able to do that so effectively in working in collaboration with criminal legal systems. I'm coming from the science perspective in hospital settings, and everything has red tape. Everything is hard to do. So that you guys were able to navigate that and make that possible is very impressive. So who's the hardest then? Who is it the hardest to engage with and to set up a relationship where they send you referrals, where the people that they encounter who could really benefit from what RCCs have to offer are being sent by them to you all? Who's the hardest to set that up with?
Justin, you go first this time.
Yeah, I think this answer for me has kind of changed since our earlier conversation. I was looking at that poll and answering that question, and there was an option on there that said other nonprofits. And sometimes to me, those can be the most challenging to work with, because okay, we've been doing really focused outreach to the medical community, to the justice community, to all these communities. So they kind of understand that there's this thing called peer recovery support services. There's this place called Wolfe Street. But sometimes when we're working with other nonprofits, reentry nonprofits, for example, they're like, yeah, we got it. We do the work. Okay, well, we could really bring value to that experience for that person who's seeking help through peer services or whatever. And sometimes we get into that like scarcity mindset or competitive mindset where it's like, oh, no, we need to be able to capture this data. We need to be able to explain to our funders that we're making the difference. But just like the recovery process itself, like we could do this so much better if we did it together. So I feel like in some ways, the nonprofit community or other helping nonprofits or human service nonprofits can be very difficult to work with in that sense. And then, my original answer would have been the medical community. I think sometimes that's more motivated by the size and complexity of healthcare systems than individuals or scarcity mindsets or competitive mindsets. But yeah, I think that's where it comes in for us.
Mm-hmm. And what about you, Andy?
Yeah, for us, the medical community, it's been a hit or miss, but we had one hospital that we were trying to work with. It's been 4 years, and we are really just about to start within a few weeks. We had another hospital that came to us, and they were desperate. So it's hit or miss on that. We really have struggled in some ways because we were started in the beginning. The original intent for the Courage Center was it was adolescents and emerging adults. So we started out was 14 to 26 and their families. Now we've moved beyond that, but so there was this push from originally to get into the schools, and not from a prevention standpoint, because we're not prevention, but we work with a local agency on prevention, but was about recovery and intervention kind of things. And it was unimaginable how hard that was, and to think that you would think that they would want a resource to come in, but we had schools that struggled to even talk to us to admit that they might have someone there that was using or might be in recovery. And we had a 15-year-old overdose just last year, and in one of the schools the parents pushed to have us brought in, and in the meeting with the administrators, they didn't say anything, and I'm wondering why they're waiting. And this one person walks in, the principal looks at me and says, "That's who we work for." And it was the general counsel for the whole school district. They couldn't even have the conversation until that person walked in. And we were talking, and we were telling like, well, hey, this next event, they invited us to it. Let's tell them that we are a community distributor of Narcan. And the general counsel said, "You can't say that." What do you mean I can't tell a school who's had an overdose? I can't tell them that I'm a community distributor for Narcan? And you're like, no. And so it's that kind of thing, and then as you're walking out, the principal leans over and he goes, "If I had my way, you'd be in here tomorrow. Every way I could get you in." So we constantly push up against this idea that, you know, we all know it's there, but we're not going to talk about it because it might, you know, give us a black eye.
Yeah, I'll second that too, Randy, because we're launching a youth recovery program this summer. It's the first program of this type in the whole state. And so schools here in the Little Rock Metroplex are like, they're really eager about it, but they're so nervous. I mean, I just talked to a school yesterday, and we had actually done a naloxone overdose reversal training with some of the students. Of course, we had like permission slips and all this stuff, you know, that they needed to do. But so we did that. And then the teacher was saying, you know, okay, well, who still needs to pick up their Narcan? And they had this like really weird process for how the parents were supposed to come up there and pick up the this, that, and the other. And I said, oh, I said, I said, well, where is the Narcan? Because like we gave it to you, right? And she said, yeah, we got it. It's in the vault. And I said, it's in the vault. And she goes, yeah, it's locked up. I said, well, that's okay. I said, I guess that makes sense. And she goes, I mean, it's a drug. And I was like, well, I guess, but you know, I mean, it's really a fundamental misunderstanding of, you know, that drug. I mean, so yeah, it's almost humorous, like how terrified of this conversation. And also you ask that same school principal or school counselor, you know, are you guys having a lot of drug or alcohol problems? And they say, no. And then you go to the assembly and you're like, hey, raise your hand if you know someone in this school who has used drugs or alcohol in the last, you know, 30 days. And there go, you know, 70% of the hands in the room, and the school administrators are like, oh, okay, well, I guess maybe we do have a problem.
And I saw Jenifer came, but just one thing I will tell you this, and I do think it highlights the difference, I think, Bettina, of how we can get in places and do things that maybe treatment can't. The other hospital that was quick to have us in, we were doing post-overdose visits already with the local EMS. So we have partnered with EMS to go visit home visits when somebody overdosed. And then so we were working with the hospital, and they were like, yeah, we're glad we got you guys in. I'm like, well, great. Well, you know, when someone comes in and after overdose, where's your Narcan or whatever? Oh, we can't give them Narcan. Why? Because we can't administer a drug, that we have to write a prescription. So literally the state agency would have been stopped. We're like, okay, well, we're just going to take them across the street to the McDonald's, and we're going to give out Narcan in the McDonald's across the street. And they're like, hey, once you're off our property, we don't care. Now, the state agency couldn't do that, but, you know, I just, you know, we're kind of, you know, the wild, wild west sometimes in the RCC world. We're just going to do what we have to do to make it work, you know.
Right. Then you do find support, and there's flexibility is being created because you see the results and you see the need. And so, and then you're blazing the path in many ways to create that. And John, I really like your comment, stigma is a life development, which is, you know, why you need to be out there and talking and getting onto people's minds to diminish that. Jenifer, so glad you're here. We are currently talking about who is the hardest agency or group to reach out to. In our poll, there was the medical communities that emerged, and Justin and Randy have also mentioned that working with other nonprofit organizations in this space can also be difficult for many other reasons. And if you're ready, I don't want to jump you in too much and rush you, but if you're ready to jump in, if you want to share from your RCC's perspective, who is the hardest to work with?
Yeah. Oh, I'm so sorry that I was we had a little situation with up here, so I was late. But I think for us, a lot of times it is the medical community, just because well, I don't know because, but you know, we have I think they look at it as either competition, or maybe they don't respect peer support as much. Which is changing a lot. I've been to a lot of conferences that in the recent year where they're acting like, oh, peer support, this is like a brand new thing and it's great. But you know, and the MOUD clinics are kind of hard to get with. I don't know if it's because their patients feel like sketched out by a being out in public and letting people know who they are. But we're working on that, slowly.
Mm-hmm.
Yeah, I wanted to say too, Bettina, that like that tension between clinical and recovery, sometimes it does go both ways. Like we kind of have to take a little bit of responsibility for that too, that tension too, because when we're talking about integrating peer services into clinical settings, there's a lot of misunderstanding between those two sides, and like it's very important that we're working together, but there's a lot of misunderstanding. And I've heard some social workers in the past, for instance, say, well, peers are coming in and doing case management. I can't speak for everybody, but I'll tell you this. I promise we don't want to do case management. That is not what we do. We want to be like force multipliers, so that when you're talking about, a clinical mental health provider over here, okay, I want you to be able to focus on the outcomes that you're focused on. When it comes to resourcing that person, that's where we can really help, is navigating those people to resources and bringing down barriers. But I think there's a lot of I think if we all had lunch together more often, we would probably solve a lot of problems together.
Yeah, and I think too, in that environment, we have to be honest, especially in the medical environment. You have highly trained, doctors and nurses and professionals. And when we first started the one project in the hospital, we brought a consultant in from another organization that had helped start, a hospital program. And he said, Randy, look, he goes, I wish there was no stigma attached to substance use, but there is. And he said, you have to look past that. Your goal is to get in there and help people. And he said, in our other organizations, some of our very best coaches weren't people that I would have sent to the hospital. He goes, I hate to say that, but it's the truth. He goes, my best coach wears death metal T-shirts and, he's this, that, and other thing. And he goes, but that's not the guy I would have sent to the emergency department at the hospital. And he said, the goal is to get a win for those folks. And so we really looked, and we've been blessed that we, had a medical social worker in recovery that we made a connection with, and some other folks like that who could go into that emergency department in the hospital and talk the language and connect with those people, because they're looking for peers too, right? That lived experience is going to make a difference in the emergency department or the hospital, just like it's going to make a difference for someone who walks through the door of our center off the street and they're looking, does anybody look like me and understand what I've been through?
Mm-hmm. I wish that minds and perceptions would change, that peer worker you talked about, who was just wearing his clothing and was authentically himself without being embraced, as like, of course you should be who you are to be most effective in what you do. Sorry, Jenifer, I cut you off. What were you going to say?
Well, I wanted to add, a lot of it is about, I see all these people wanting to integrate peer support into their clinical settings, and I think it's really important that we talk to them about infusing peer support and utilizing an RCO as a partner, because as a recovery community center, we can provide that supervision to a peer, whereas if they're like just hiring a peer in, then they don't have people in peer support that are equipped to supervise other peers. They have clinicians that are trying to supervise peer support, and they're very different things. And so that's a good sell, where we can, say, hey, we do this is what we do well, and we should partner with you instead of, and, we have in Georgia a statewide RCO called the Georgia Council for Recovery, and they've been really great about pioneering this and having pilot programs in hospitals. And so now we're able to have a model that we can use and say, look what they're doing. And we work with them to figure out the best way to provide that for you guys. So I think that's great.
Yeah. And we have some comments in the chat. I do still want to get to the other piece we have and then circle back to Virginia and Cindy Marie, because your points are also spot on. But let me just transition us to the other part as well, so we can consider that. Because you were saying, the integration of the staff into hospital setting is one thing, but the setting, and I think Justin, you talked about how, or was it Randy? One of you guys mentioned like how the office, I think it was Randy, that the office really reflected who the person was, and that's maybe not something you can do in a medical setting. So, there is a value in just having it be like that. So let's keep these thoughts in mind, and just Olivia, if you could screen share the other piece that we wanted to have, because we did talk about specifically about outreaching to communities that we don't otherwise get, and to people and groups that we don't usually get. In our survey, the nationwide survey that we had done, we were good enough to ask some anti-racism questions. We didn't think of and should have thought about to also ask questions about LGBTQ communities and other minoritized groups. But the take home here really is that there is a lot of openness. There's, 95% of all the RCCs take an active anti-racism stance. And here are just some of the examples of how that actually plays out in terms of, making sure the policies and protocols don't have discriminatory practices, creating safe spaces, encouraging employees and participants to speak out. There's a lot of activity and a lot of motivation and a lot of openness in the RCC space. And then I wanted to ask you, and we can stop screen sharing again, Jenifer, Randy, and Justin, for you all, is that an active thing where you're saying we're looking at our demographics and we're realizing we're not reaching XYZ? How can we change that? How do you all handle that? I know it's a hard question.
Yeah, I mean, we as I mentioned when we met previously, it's very important for us that our staff and our board reflects our community. And we're really interesting because we started in the suburb of Columbia, which is very white and affluent, and then we opened an office in another part of Columbia, which is the exact opposite. And so, for us, having staff that looks like the people that we're trying to serve is important. And, even from a diversity standpoint around, LGBTQ issues, right? We're looking for people who have a passion for this kind of work. I'm not looking for people who check a box. Right. But we want, we're always asking, hey, who else in the community here that is passionate about this that we could talk to. And again, sometimes the work that we do and the people that we're trying to reach, that we did a peer support class not too long ago, and there was a young African-American man there, and I heard him talking to someone in the class, and he was talking about how he'd been incarcerated. Now, before in my other lines of work, I would have went, ooh. I ran over all excited. You were in jail? That's awesome, man. Hey, when you get done with the class, can you come talk to us? Because here was someone that's already shown that they're looking to do this kind of work. And, and he did fit exactly what we were looking for, because people are looking at is this a peer? Does he understand the world where I'm coming from? So that's important to us. And we talk about it in board meetings, and we talk about it among the staff.
So definitely on the radar, just there are challenges.
Yes.
Mm-hmm. Justin, Jenifer, what about you? How you guys handle that?
Yeah, I would say, a really crucial step that I think gets missed sometimes is recognizing that we have a problem. And so for our organization, the Wolfe Street Foundation started in 1982, and the majority of the folks who started the Wolfe Street Foundation were Black. And you look at our board of directors and our staff today, we're mostly white. And so that shift has happened over the historically Black organization has kind of turned into a mostly white organization. We still are very engaged in the Black community here in Little Rock. We still have a lot of what I would describe as historically Black AA and other mutual aid support groups that meet at Wolfe Street. But somewhere over that period of time, what we looked like started to shift. And so we're in that phase where we're recognizing, okay, we have a problem. And because we want to look like the people that we serve, not only with lived experience, as a recovery community organization, the majority of our board are people that are personally in recovery. The vast majority of our staff are people who have personal experience in recovery. But we need to be more focused on inviting people of color, inviting people from LGBTQ plus communities to not only like come alongside us and do the work, but to share in the leadership of our organization. And so that's where we are right now, is recognizing that there's a challenge, and also recognizing that particularly in a lot of Southern communities, vast portions of our life experiences remain separated by racial lines, and recognizing that, hey, that's going to take some effort to make sure that we are a space that is safe and healthy and welcoming to communities who have been actively harmed by systems that have actively benefited people like me and many of our staff and board members, is a challenge. And the greater challenge is I've looked with great envy on some of my colleagues who have brought in some consultants and who have done some really good community engagement. And it's finding the funding for that kind of thing in the current atmosphere in the South is really tough. So, but I think that's a really important step, is to say, hey, we have this problem, and then also to be disciplined enough not to say, all right, that community should take responsibility to solve that problem for us. We need to actively engage in that process.
Very cool. And I was going to say, so Cindy, would you be comfortable mentioning, you mentioned here Dr. Deidre Hawkins, who's doing consulting. Did you want to just elaborate, since Justin also just mentioned what such a consultant would be able to provide? And maybe that could be done in different ways, like by Faces and Voices. You probably do something like that too, where you share information. And so Cindy,
Sure.
Would you be perfect?
Yeah, absolutely. I want to also just thank, this is such an awesome moderators here. I'm learning so much. It's great to be on calls with RCOs throughout the entire nationwide. It's really awesome. With the good work we're doing in New Jersey. So really, Engine Cars is like a statewide RCO. And we do a lot of great work with not just individuals in recovery, but with families and other statewide organizations. And one of the things that's been immensely helpful with us is working with Dr. Deidre Hawkins from Both And Partners, who really worked with us to look at our systems and not look at what we don't have, but what we do have. Using a lot of work, instead of, doing the SWOT analysis that everyone knows, we do like the SOAR analysis, right? So strengths, opportunities, aspirations, and results. And this has really transformed our organization. This is something we started in light of George Floyd in 2020. And we didn't want to be that organization that just puts out a statement, right? A statement saying this is bad. We wanted to actually do some real work. And by doing that, we were able to bring in our membership. So having race equity dinners, meeting with people and having conversations, because where real change happens, and if we're going to be trauma informed across this continuum, is really with conversations. So just thought I would share that, and I added the link just because she's that amazing. So if anyone's interested, please reach out to Dr. Hawkins. She's based in Atlanta.
Awesome. Thank you so much, Cindy. We really love that you put that there. Jenifer, how's it looking in your side of the world?
Yeah, so I know we talked about when we practiced this that our community here in Jackson County is 90% Caucasian. So it's really, we're looking at the numbers that we're getting, taking people's demographic information and trying to see like what is reflected in the population that we're serving. What percentage of our peers are not Caucasian, how we are going to reach out to them. We've partnered with a lot of the Black churches in our community. We had an opportunity to go speak like during a church service. It was great. They let us come in and talk about, what we're doing. We do a lot of outreach at, church events and things like that. And then our other effort that we're making is partnering with our accountability courts, because we noticed that there is a huge disparity in their demographics and how many people they're serving of different colors, it's definitely one-sided. And we are working with them to analyze, you know, why that is. Is it because of the charges that people get are different? Is it because the DA's office is picking and choosing who gets the opportunities and who doesn't? So we are, you know, making those strides. It's really hard to tell in our community, you know, because we are so predominantly Caucasian in our area, like, are people having a problem and we just don't know them because they're not coming to us because we look different? So, and we're always looking for board members that fit into our values and, you know, what we're trying to do, while also not being like, oh, well, you're a person of color, can you be on our board? You know, because that's not that's not what we want to do, you know. And I think Randy had, you know, kind of referred to that in talking about his staff, and it's challenge here. But you know, we're working through it, and with the LGBTQ community, we're doing great. You know, we have another organization within a few miles of us that is called Inclusive Recovery Athens, and they are very focused on helping people who are in that marginalized population, who are trans, who don't feel safe in other spaces. And so we work with them a lot to, number one, make sure that we're doing what we need to do to make people feel safe and valued, and like we are informed about practices, and also if they don't feel comfortable because of the trauma that they've been through, we have someone else to come in or to, you know, hand them off to, so that we're making sure that everyone gets what they need.
Yeah, I want to say too, I mentioned in our earlier conversation about just being mindful of what resources are available. You know, I mean, we're in the South, we're in the Bible Belt, and so being mindful that, okay, you know, a lot of people from the LGBTQ people have not had good experiences at faith-based treatment or faith-based recovery places. So we need to make sure that, you know, the only resource we have for treatment for someone who doesn't have insurance is a faith-based organization. That might not work for that person. And so just making sure that we're responsive to the needs and preferences, and being culturally competent in that way, especially with that population, is really important. And something we haven't really touched on too is like language diversity. We have a lot of Spanish speakers in Arkansas, but you get to learn something unexpected today, which is that the largest population of Marshallese people outside of the Marshall Islands lives in Northwest Arkansas. Huge community of Marshallese people. And so it's not just about thinking about, oh, okay, maybe we should have those flyers printed in Spanish too. Like, do we need to have, you know, Marshallese language resources available? Do we need to have someone who can help break down like legal documents for someone who speaks a totally different language, other than just what we think of as an English-Spanish dichotomy? You know, there are so many nuances to that cultural competency conversation, and it's a challenge, but it's something that we really need to commit to, providing access to all people and striving for health equity in that way.
Yeah, that's awesome. I thought too, Justin, while you were talking about, you know, making sure that we have diverse programming and diverse pathways to recovery. You know, we're not just saying, oh, we have 12-step meetings here, or, oh, we have this celebrate recovery or whatever, you know, making sure that we have an eclectic mix of different options for people to choose from, because different people are going to want to pull from different things and have different pathways to getting well, things that work for them.
Yeah, and we've had to be proactive in that way sometimes, like just because of the way that the way that we were founded and have evolved since then. Like we got some pushback on like, oh, okay, well, we need more access to NA meetings specifically, like big requests for that. So in those situations, we can reach out to the existing community here and see if they can And then we started realizing, well, there really aren't a lot of non-12-step opportunities. So we helped a group start up a refuge recovery meeting, which is a Buddhist faith-based 12-step program. We've hosted Christian faith-based things here. And then we got pretty proactive and said, well, if there's a lack of resources in multiple pathway recovery, then maybe we should be hosting a smart recovery meeting, or just an open all recovery meeting, or just creating spaces and opportunities for folks to get together outside of, more traditional pathways to recovery.
Yeah, it's interesting you say that. We were looking at, some expansion. We were having an expansion discussion a few weeks ago, and one of our new staff members was on board, and I mentioned another county over, and they're like, oh, I said, because there's really no recovery community in that area. And they looked at me and goes, what do you mean there's a huge recovery community? I said, really? Tell me about it. And basically they started telling me about this gigantic AA meeting that had a building and had all these meetings. And I just listened for a while, and I went, well, that's great. I said, do they have any harm reduction activities? Do they have multiple pathways? Are they working with the criminal justice system? Are they working to get in the hospital? Are they working in schools? Are they working in, and by the time I rattled off about 15 things that we do, they went, no, they don't do any of that. So it is this idea that diversity's got to be in not just the people and the color, but the diversity of the people that we reach, the programs we offer, because that's the strength. I think part of what the RCOs offer is that multiple pathways, that we're going to do anything that moves the recovery ball forward, and we're the same way. We've hosted 12 steps. We got too big and they decided to go someplace else. But I tell people all the time, you're more than welcome to come use our building. And we host a grief after substance passing group. We'll open it up to anybody, but it's got to be, more than, look one way.
Yeah, and I think it sends a powerful message that people just check out the program and they see different options. And even if your own option isn't there, whatever you choose is going to be well received, because there's just an openness to different pathways there. I think it's a powerful message. Very, very cool. So I will say that we are nearly at the end of our time, the recorded part. We're going to be having an extra half hour for all of you who have a moment to stay and can still talk with Randy, Justin, and Jenifer with questions and comments. Olivia, if you can just, actually, we don't have to screen share for that, but if somebody wants, Al, if you want to put in the link for the registration for the next seminar, the May seminar, we're going to be talking with prescribers to ask them what are the barriers for the medical system to work more closely, to refer out to RCCs. It's sort of like what would be in the way of making it standard of care, that medical systems would just send folks over to RCCs. So I hope you all will be there for that, and we'll tackle those questions from that perspective. And please be there and ask the questions that we raised here today.